Okay, at long last, the best part of our presentation, I hope, is Sally Hamour. Sally, I hope you're there.
I'm here, David.
Great. Okay, well, thank you so much for joining us.
So thank you very much. So first of all, just to say how glad I am and grateful for the invitation to meet so many of you, and there are many familiar faces I can see in the attendance list as well. So that's very nice indeed. I thought I would just, as David said, just for about 10 minutes, I just wanted to introduce myself, tell you a little bit about the unit and where we are at the moment, and then tell you some of my thinking about sort of the challenges and the things that we'd like to achieve over the next couple of years, and tell you again, looking back a little bit over some of the challenges of the last 2 years, which obviously have been quite significant. So I'm Sally Hamour, and I'm a renal consultant at the Royal Free, and I was appointed as a consultant in 2013. My relationship with the Royal Free actually began almost 20 years ago, because I was an SHO in the renal unit at the Royal Free in 2001, in one of my very first jobs at the Royal Free. And then I went away for a bit, and then I came back, and I was a registrar for a couple of years as well, and then I went away for a bit, and then eventually I came back as a consultant. So the Royal Free is very dear to my heart. And in January, I took over from Dr. Jenny Cross, who many of you will know very well indeed, as clinical director. And at the same time as that happened, the hospital had been restructured a little bit, which meant that we, the renal unit, together with urology, became a division. So my title was officially Divisional Clinical Director, which didn't really mean very much for renal and urology, but what it does make a difference to is our relationship with the leadership of the trust, because now we're slightly higher up, if you like, in the hierarchy. So my line manager is directly the medical director of the Royal Free, who's Gillian Smith. And it means that as divisional clinical director, I attend trust board, for example, and I meet regularly with Chris Strether, who's the group medical director. And I think what those changes in the organisation of the hospital have meant is that I think our voice is heard much more clearly and easily, which is important for us and important for our patients, than it was before, when there were multiple layers of admin and hierarchy, if you like, to go through. So I think that's been a really, really positive thing. And you probably know as well that in renal we've been very fortunate, and that we're very well placed within the Royal Free. Lots of people from the renal department hold some of the senior management roles at the Royal Free. You'll know that John Connolly, who's a former renal consultant and then medical director, is now chief executive of the Royal Free. And Rebecca Longmate, who's director of nursing at the Royal Free, started off as a dialysis nurse. We have Anya Burns, who's a renal consultant, who's the lead for postgraduate training, and so on. And Gillian Smith is also, who's the medical director, is a urologist. So I think we're very fortunate in that sense. I don't think we get any special treatment, but I think we have a lot of senior people who very much understand our services and our needs. And I think that's a very helpful thing indeed. And my interests before I became clinical director, I'm still doing all the same work essentially, but just so that you know, I know many of you know this already because you're familiar with the clinics that I do, but my interest from a medical point of view is sort of immunological renal disease, glomerulonephritis, vasculitis and lupus. And so I do the Monday and the Friday vasculitis clinics at the Royal Free, and work very closely with Alan Salama, whom I've known for a long time, and Anya Burns and Ruth Pepper, and we run that service. And I also share a cohort of transplant patients with Alan, so I do one of the transplant clinics. And I also, since I was appointed as a consultant for 8 years, I've been one of the dialysis consultants at Tottenham Hale Kidney Care Centre. And I also am in charge of the undergraduate training for all the UCL medical students as well. So I would say that's kind of quite an unusual portfolio, but I think it gives me a really good insight into a lot of different areas of the work that we do. So that's, I think, probably left me pretty well placed for taking things forward as the clinical director. I just thought I'd introduce, there's a few new posts, and I don't know if you're familiar, but just in case anybody isn't aware of sort of who the leads in the service are. So again, with the restructuring where I became clinical director, they appointed heads of nursing to lead 2 divisions each. So the head of nursing for renal is Damir Tandarik, and he's head of nursing for nephrology and urology, and he's also head of nursing for cardiovascular. And many of you will know Damir, who's an incredibly capable man, because he was, prior to this appointment, he was our dialysis matron. So very fortunate indeed to have Damir in that position. And then Gareth Jones, who's our transplant lead and has been for many years, and Kate Goodlad, who's our dialysis lead. Similarly, I think they're probably very well known to you. Sarah Milne is one of our clinical nurse specialists and our lead nurse for nephrology. And Sarah's acting up at the moment as the lead for chronic kidney disease and outpatients, and is doing really great things in some of our chronic kidney disease work and liaison with North Central London in terms of our efforts to do more case finding and preventative work and education in primary care. Phil Masson's our inpatient lead, and then Sinead Burke's been around for a good while as our lead therapist. And I know that you're quite familiar, I think, with our psychologists, Jeff and Sarah. Okay, so I'm just going to talk through just this slide really, and just tell you a few things that are on my mind, if you like, and then I can show a couple of slides of data, or we can stop and take some questions. So, so as I say, I think we're really fortunate to have such a committed and well-organised KPA at the Royal Free, and it's something that we, the staff, really value. And I'm very keen for us to have the opportunity to work even more closely in terms of what you feel the priorities are and what we can do to improve the way that we deliver care for kidney patients, and to really work together in terms of designing our services. Jeremy, have you got your hand up?
Yes, Sally, your slides aren't actually showing up on the screen.
Oh no, I'm going to stop sharing. Can you see me at least?
Yes.
Okay, all right, so I'll just talk you through what some of my thoughts are in terms of what we'd like to sort of achieve over the next little period. So everything that we do, we've done a lot about the methodology of sort of quality improvement, and everything that we do, we want to obviously be driven by quality improvement and improve patient experience. And the last 2 years have been really challenging for all of us, incredibly challenging for our patients in terms of sort of shielding and sickness and all the changes that occurred to all the services that we deliver, the suspension of transplantation for 6 months in the first surge, and then the changes that we made to the way that we deliver outpatient care, for example, the move to video and telephone consultations, and then through sort of vaccination. And now there've just been so many changes, it's hard really to quantify it all. And oops, I think someone's just not on mute there. And so it's been a real learning curve, and there've been lots and lots of incredibly difficult things and lots of huge challenges to try and continue to deliver all of our services through that period. And I don't know if some of you might know sort of some real low points in the first surge back in March of 2020, when, for example, we had 76% of our nurses at Tottenham who were off sick with COVID and really almost unable to deliver the service. And you know, I still remember that Saturday night getting the email from the nursing staff, and we had about 2 weeks when all the consultants were going out to Tottenham and working shifts as healthcare assistants, just to try and free up the dialysis nurses as much as we possibly could to actually deliver the dialysis for patients. So we're a long way from that. And as I say, there have been some huge success stories as well. And one of those success stories at the Royal Free has been transplantation, because although we were closed for a number of months during the first surge, what has been absolutely fantastic and supported by the Trust has been the fact that we've been given a secure isolation ward so that we can continue transplantation. And the Trust has really prioritised keeping transplantation open at the Royal Free. And if any of you have heard Gareth Jones talk recently, you'll have probably heard him say that we were in the last surge, we were the last to close and we were the first unit to open. And in London, we were the unit that preserved the biggest proportion of our transplantation compared to every other centre. And we've had really good secure infection control policies as well in terms of protecting our acute transplant patients from infection with COVID. So things like that have been a real success story, which has been absolutely brilliant. And you know, there's no challenge and adversity that comes without the potential for change and for innovation as well. And so there have been some things that I've been wanting to do for some time, like the telephone clinics, which were fraught with bureaucracy and trying to make changes. And then when COVID came, suddenly almost overnight we could do telephone clinics and we could do video clinics and all of those sorts of things. And that's obviously, you know, for patients who want it, it's absolutely brilliant. You don't have to drive, you don't have to wait ages for parking, you don't have to wait in the waiting room. You can have your bloods done and then have your consultation with your consultant at your convenience. So I think some of those things have been really positive changes that have had a great impact on what we can deliver and how we can do it in a more environmentally friendly way. And I'll come to that in a bit, but also in a way that's more convenient for patients and allows them more flexibility. We've got a few challenges coming up still, I think, in terms of COVID. Obviously, we're just working our way now out of the last surge. And as many of you will know, the workload for NHS trusts has been absolutely enormous over the last year. And that's not just COVID. A lot of that is business as usual, but in higher volumes. And we in the renal unit have really been at the sharp end of that, partly because our patients have been so vulnerable to COVID. So we've been hit a lot more than other specialties. We've made a few changes to try and improve outcomes for our patients. So in the first surge, we had all the dialysis patients brought directly to the Royal Free rather than going to their local hospitals. And that still continues, which is, I think, the right thing to do and a really good thing. But it does mean that we have more inpatients and we put more pressure on our emergency department. And so our workloads continued at a higher level than previously. And then the other thing I'll just mention, as you all know, vaccination for all NHS staff is going to become mandatory from the 1st of April. And so there's this new acronym now called VCOD, which is vaccination as a condition of deployment. And so for the minority of staff who are unvaccinated, and it is very much a minority, there's a lot of work going on in terms of conversations and discussions and trying to move people towards a point where they feel that vaccination is acceptable, because from the 1st of April, there will be no other alternative for people who want to continue working in the NHS. I do want to mention transport, and it was, I know both Geoffrey Barnett and Dave Collins, so thank you very much for that, Dave. It's hard to say anything about what affects patients in terms of their care without mentioning transport. It's really difficult. It has a huge impact on quality of patient experience, especially for dialysis patients. It's a huge source of frustration for patients, but also for the nursing staff and the admin staff in our units. And we know that it's a really constrained service. That's only become more challenging in COVID with the broadened remit of transportation for patients on dialysis, and with the social distancing requirements, with the isolation requirements. I think I have to say that it's a work in progress. We know it doesn't just affect our department. Of course, it's a sector-wide problem across North Central London, and we have inadequate resource there. But of course, if you're using patient transport 3 times a week, it's going to affect you disproportionately. We have talked about this at Trust Board more than once, and I would say that we've been successful in getting a critical eye on this at high levels in the trust, which I think will be very helpful. Many of you will know that Kate Goodlad has done huge amounts of work on this as well, but we definitely haven't got it right yet, but we'll have to keep working and see if we can get some improvements in the service to a level that's acceptable to people, because I think at the moment we're still very, very challenged, and everybody absolutely recognises that. So I'll just say a few things. So first of all, just huge thanks to the KPA. I'm on call at the moment, and I joined, I think, just as Dave was talking about some of the things that the KPA has helped with for patients and for staff at the Royal Free, and a couple of things that I've just been involved with recently. Number one, the recliner chairs for the inpatient service, which have been absolutely brilliant. So thank you very much indeed for our step down patients from intensive care and so on. And the other thing that has been more than fantastic is the audiovisual equipment for the renal library on the 3rd floor, which has been absolutely transformational. I mean, we use it almost every day, and it's enabled us to share patient information, have meetings with other people, even our handovers, to be able to comply with infection control now. Some of us can be in one room and some of us can be in another room, and the quality is absolutely brilliant. So thank you very much indeed.
Right, good, thank you.
So just a few, and I'm going to just as the last thing, just to touch very briefly on the challenges, I guess, for me and for everybody in the next couple of years. So one is the inpatient service, which, as I say, is getting busier and busier and busier. And we'd like to twist the arm of the trust to give us another half a ward to be able to cohort our patients and deliver renal care more easily and more efficiently and more effectively, and also to provide a service for intensive care, because the renal team have become absolutely critical during COVID, because there's been such a demand on intensive care beds that they've really needed us to take all the patients who are ready to come off intensive care apart from their renal failure. So we've become a really important cog in that process, but I think it's given us a lot of leverage across North Central London, which will be really helpful. Dialysis, we've done really well on our numbers of patients on home therapies during COVID. That's largely peritoneal dialysis. We're up to about 185, I think. Numbers on home hemo are much smaller, and I think that's an area that we can really work on. But overall across London, there's quite a sort of significant prediction in the rise of numbers of patients on dialysis. So number one, of course, we want to grow transplantation, especially living donation, to try and give as many patients as possible from as many different demographics as possible access to transplantation. But we also need to do future planning and future proof from what's likely to be an increased demand in dialysis capacity. And, you know, all sectors are facing that, all parts of London are facing that. And it's going to be a real challenge, because obviously dialysis requires such a lot of capital investment and infrastructure in order to deliver in-centre hemodialysis. Great work going on in transplantation, much of that helped by the KPA in terms of the projects helping to raise awareness and encourage donation and living donation. So that's been absolutely fantastic. And then the other thing that I just touched on at the beginning was Sarah Milne, our lead nurse's work on preventative work, education in primary care, and trying to prevent the progression of chronic kidney disease, so that we have fewer patients getting to the need for dialysis, or at least that we can slow it down and it happens later. So that's really, really important. And then the last thing I just wanted to say, which is a topic close to my heart, is the topic of green nephrology and trying to make the way that we deliver renal care more sustainable and more environmentally friendly. And we've reinvigorated the sustainability group, and we've got a couple of really great things, I think, that hopefully will come to fruition. So the first of those is so obviously every patient who has dialysis has their dialysate, and that's delivered in a plastic bottle, and we use about 40 or 50% of that, and we throw the rest away. And we generate hundreds of thousands of plastic bottles every year that we then have to pay somebody also to come and take away. Is to get our dialysate delivered into big centralized containers instead, and that's going to do away with the need for the plastic, do away with the waste from the dialysate, do away with the manual handling of the staff having to transport all of these millions of containers on pallets, and do away with the costs of having to take them and pay someone to take them away at the end as well. So we think it's actually going to be cost saving, it's going to be massively environmentally friendly, and it's really going to improve the sort of what the staff in the dialysis units have to do as well. So I think that's going to be a really, really positive thing. And the other thing that I hope that we're going to be able to do is to think about how we use the grey water that's wasted on dialysis, which at the moment is millions of litres of water a year. And a lot of that can be used for other things like flushing toilets in hospitals or watering gardens or different things. So we're trying to think around that and incorporate some of these green policies into into the way that we work on a routine basis. So I think I'll stop there. Thank you all very much indeed for giving me the opportunity to talk to you and to meet you all. Really, really keen to, as I say, have you involved as much as possible into helping us decide what the right directions are and what the priorities are. And clearly our patients are at the heart of everything we do, and we really want to share those decisions and those processes with you. So thank you very much.